Hi, welcome to the It's Your Money and It's Your Estate Spring 2025 workshop series, brought to you by our 501c3 nonprofit organization, Financial and Estate Literacy. Our mission is to empower you to take control of your finances, your estate, and your charitable giving decisions. For the past 25 years, our founder, Peter Kote, as well as our entire team, have been providing these free, unbiased, and accessible 6-week workshops all over Orange County, California, as well as online, to help you make informed decisions that align with your unique needs and values. Now, let's start the program. This webinar is the third session of the It's Your Money workshop series. The topic of the day is medical care planning. Our moderator is Peter Kote, and our guest speaker is Leanne Godfrey. Enjoy the workshop.
Let's get started on our program. Leanne, why don't we come on screen? And I think, Eugene, you're going to have to let her in. And there she is.
Oh,
And
I'm very orange.
yes.
My colors have changed. Oh my gosh.
Um, you look great.
Sorry, I'm working on it.
Yeah, good.
I don't know why it changed.
There you go.
Okay, this will do.
There you go. Why don't we put your Ask First form on the screen? And there it is. Okay. And scroll down just a little bit just so we can get you. All right. Bachelor's degree. Where'd you get your bachelor's degree?
So my bachelor's degree in nursing is from the University of British Columbia in Vancouver, BC.
Oh, we got a Canadian.
Representing.
Good. Um, how long have you been a registered nurse?
So it's going on, I graduated in 92. So I'd rather not do the math, but it's almost 35 years.
Okay.
Yeah.
And today, you're a care manager and you're certified, but what does that mean?
Well, being a certified care manager means that you have done a certain number of hours of care management services, provided a certain number of hours, and you've also written an exam that covers a lot of different topics, all the way from benefits that people receive, all the way through some medical kinds of questions that they ask on this exam. It shows that you have an understanding of how to coordinate care, how to communicate with healthcare providers as well as family members, etc. That you have a basis of understanding of resources in the community to be able to link people to those resources for their best outcomes in terms of health management, just life management, actually. So it's an exam that not every care manager does, and there's no requirement. It's voluntary, but I think
But
it just it's another level.
you're using the term care manager. Uh, what does that mean? And there's not many individuals like you in the community.
Right,
So you're independent. You don't work for a major corporation or firm.
right, right.
Can people, just ordinary individuals, hire you?
Yes. So most of the people who hire me are regular individuals. They're families. They are individuals who are trying to age in place in their home. In care manager, Pete, the term is really overused. And I think that a lot of people use that term. They use case manager, care manager. It can mean someone who works for a home care company that schedules caregivers. It can be someone who is like myself, a nurse who provides oversight, assistance with navigation, advocacy for my clients, people that are trying to coordinate their healthcare. But it's also used by many, many other people who are doing different roles. So as we'll talk about in many of the things we're doing today on this webinar, you want to ask a lot of questions. If someone says they're a case manager or a care manager, what does that mean? Are you a gerontologist? Are you a social worker? Are you a nurse? Are you someone who works for a home care company or a home health company? And what does that role involve when you say that you're a care manager? So it's asking those questions to determine the details, because again, it's a very overused term out there.
Yeah. I have used Leanne on with clients when I'm named as the healthcare agent,
Mhm.
and I have to make decisions on behalf of the client on possible medical procedures, on who to see as to get medical advice, to help with prescription drugs, to hire caregivers. Um, I am not steeped in knowledge in the medical industry. And so having someone like Leanne help me make decisions on behalf of my client is absolutely, you, there's no price for it. Um, you, is there a licensing procedure for a care manager?
There is not. The only thing we have right now is a certification process that we just talked about a few minutes ago. But there is an organization, and I do have a slide that we'll share shortly.
Okay.
It talks about the association that many care managers belong to. And again, it's a voluntary organization. You don't have to belong as a care manager, but it's encouraged. You know, you get education, you get camaraderie, you can collaborate with your colleagues. And we'll talk about that, but it's the Aging Life Care Association. And if you're looking for a care manager that can help with navigating the system, going to doctor's appointments with you or your loved one, you can go onto that website and put in your zip code and find a care manager who is close to you in terms of proximity. And you can see what they are, if they're a gerontologist, the social worker, the nurse, whatever background they have, and you can see if they might be a good match for your needs or your loved one's needs. But
Scroll down,
again,
scroll down a little bit more. You put your client's best interest first.
mhm.
How are you paid?
So we're paid privately. There is no reimbursement through Medicare or Medi-Cal, any organization like that. So it's all out of pocket. And again, asking the person that you're interviewing how much they're charging and how they charge. So most of us charge hourly, and it's like an accountant or an attorney where we add up the minutes that we've used on the behalf of our client, and that's how people are billed every month.
And what is your rate?
My rate is 170 an hour, and in Orange County, you're going to see probably rates from about 150 to 250 per hour for this kind of service. So it's always worth asking before you get down the road very far how much the rate is.
Yeah, but you don't spend 24/7 with the client. It's
Right.
usually you're training. The person who needs to really know you is the attendees who are listening to this, their agents for their healthcare.
Right, exactly, exactly. Most of the people I'm interacting with are people who are the loved ones. Maybe they're the durable power of attorney for healthcare. As you say, Pete, it's the agent that's been designated. Many of the clients that I have cognitive challenges, so I'm working with them, you know, but I'm also talking with that agent and explaining what's going on. I am not the decision maker. That's not my role, but my role is to educate that agent if the
As
person,
to the
yeah,
alternatives available, and
yes,
and you're out in the community, in the medical community, and you're familiar with what's going on.
right,
Whereas a person's agent, this might be the first time that they're dealing with the illness or dementia or a stroke or brain injury or whatever is the cause of the lack of capacity. This might be the first time they're dealing with that.
absolutely. I can't tell you how many times I get a call and they say, I just don't even know what to do next. I have no idea what to do. So it is nice to have someone to be able to provide that guidance and that education and that support because things move fast sometimes and you have to make decisions.
Yeah.
So that is the role of the care managers to help with that.
Yeah. So everybody who's listening, whether or not you please save Leanne's Ask First form and spread the word that because this is a fairly new profession, isn't it?
It's relatively new in comparison to others, yes.
Yeah.
But it did start in the 1980s. But I think, again, it was a very limited number of people doing this kind of work, and it's getting to be more prevalent now, thankfully. People need options for this kind of care and support.
Yeah. As a professional fiduciary, I mean, we use Leanne and her and others like her all the time. because we're not medical people. We don't have the terminology down. And in order to do what's best for the client, you need somebody who's knowledgeable. Let's go through your outline. Oh, by the way, you want to go through just a little bit? The reason I'm the one that told Leanne to put this on the screen because I love that quote. Every time I feel like I just can't do it anymore, I'll have a resident say, "You are my guardian angel." That's you could substitute that photo with Leanne's photo, and Leanne is the guardian angel, and they're the unsung nursing heroes in the community, and they're an advocate on behalf of the client. And if the article will hopefully be online, take a read. I'm so happy to hear that you're finally getting some publicity on a national level of your role because as you go through the program today, you'll see some of the issues that we get involved in. Let's go to your presentation.
Okay, let's do
Little
that.
technical. Share
There
your
we go.
screen.
We're popping all over the place. It's all good though. All good. Okay, so we've talked a little bit, Pete, about the care manager role, and I
We
think
need
that we
your
can.
outline up.
I'm sorry?
We need
Oh,
your outline up on the
oh, you're
screen.
not seeing it. Oh, I'm
No,
seeing it. Sorry.
that's okay.
That's okay. Here we go. This is why we practice, so we don't have this happen. Sorry, Pete, it's gone away.
So we'll be while she's getting the outline up on the screen, and we go through the.
Sorry,
You
maybe
got
my
this.
glasses will help me.
There you
I
go.
had this up.
Yep, you did.
I did.
We can always put it up online. Eugene can put it up online as well. Um,
Okay, hang on.
Hang on.
Tell them what's coming up next week.
Uh,
I don't know why it's not
next
sharing.
week we get back into the money issues, but one of the things that we're going to be talking about is the money issues that are
Share.
involved in medical care planning, and 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 it follows our last session of financial planning one, where we discussed knowing your net worth, understanding your cash flow, and understanding what medical benefits are available to you, and we're going to be talking about that in just a little bit. One of the things that we need to know is the terminology, and in terminology we need to know the when you go into the hospital, you're going to go into the hospital because of acute care, and we're starting to get there.
We are.
Yeah, we are.
Sorry
And
about that. I don't
no,
know
that's
why it
okay.
wasn't there when I wanted
Here
it.
we
I
go.
apologize.
Not a problem. So we talked a little bit about okay. Here we go. Terminology is really important here. We talk about levels of care, and what does acute care mean?
So, in terms of your acute care needs, if something happens, this is with a person who ends up in the emergency room, they are admitted to the hospital, there's something going on, perhaps a stroke, maybe there's been a cardiac arrest, there's an infection, body-wise sepsis, something like that, where someone is acutely ill. This is not a chronic condition, or it could be a chronic condition that has an acute exacerbation. But really, the acute care that's needed is to be hospitalized. Many people these days are kept in observation for several days before they're either discharged or admitted to the hospital. Unfortunately, that is happening more and more, and you might see that with your loved ones or with your own health these days. There's a reluctance sometimes to admit, but if you are admitted to the hospital, there's something acutely going on, and they're not going to keep you very long. As soon as you're ready to go, they're going to want you out. They're going to want to discharge you back home or maybe to a skilled nursing facility.
And who's in charge of you at the hospital? Your primary care physician?
Right. So your primary care physician won't see you while you're in the hospital, but a hospitalist will. And that's sort of a general physician who's going to be following you through your hospital stay. Of course, there's going to be specialists that come in to see you, maybe a cardiologist, depending on what's going on, of course. But maybe there's a nephrologist if your kidney function or your loved one's kidney function has deteriorated, that they're very concerned. But the hospitalist is really leading the team there. And this is someone that doesn't know you, you don't know them.
So it's really important that you complete your advanced healthcare directive and
Yes.
that your agent, whoever you've chosen, one, location wise, can get to the hospital
Right.
and talk to the hospital staff because they won't know you.
Right.
Two is that can you get prescription drugs that you might be on? Or maybe you're allergic to different things. Um, your agent again needs to communicate with the hospitalist at the facility at the hospital. Um,
I think there's an issue there that you bring up, Pete, that is people assume that when you hit the ER that they're going to know who you are, they're going to know what medications you're on, they're going to know your background, they're going to understand what the healthcare situation is. And I think it is a much better way to go to assume they don't know all of that. And with the sharing of medical records and electronic medical records these days, it is better, but it's not perfect. So having an agent that knows what's going on with you, knows the medications, all those kinds of things are important as you enter into the acute care system.
Yeah. So, so it's a great idea if you've named your agent in your healthcare documents, make sure that they have a copy of it in their glove compartment.
Mhm.
And this is not a document to keep secret, and get it out there. Today, the most of your when you are admitted to the hospital, you're going to be asked to complete an advanced healthcare directive before you're admitted. Not a great time to complete one of those.
Mm.
So do it ahead of time. Being admitted is really important because you can be in the hospital or in the ER room under observation, as Leanne was talking about. If you're just on Medicare, we're going to talk about Medicare in just a little bit. But you have, if you're admitted you have to be in the hospital for 3 days plus one in order to get skilled care paid for by Medicare. What does skilled care mean?
This is the place that you're going to go. Oftentimes, they're called skilled nursing facilities or SNFs, nursing home, rehab facility. And once you're discharged from acute care, this is a place where you can go to have rehabilitation, whether that's with physical therapy, occupational therapy, speech therapy. And speech therapy also includes cognitive kinds of assistance as well. So it's not just speech. Sometimes people say, my dad doesn't need speech, he's talking just fine, but it might be more of a cognition kind of oriented therapy that they want to do with dad. And this is a place where you're going to have skilled nursing facilities. You're going to have CNAs or nursing assistants, rehab assistants running around. And they don't want to keep you forever. They want to be able to do rehabilitation and then hopefully release you back home if that's possible, or maybe to a small board and care. And we'll talk about board and cares in a little bit as well. But it's really a place to get stronger, to receive any kind of treatments. Maybe there's some IV therapy that needs to happen. So all those kinds of things can occur within the skilled environment.
Yeah. Um, what I'm seeing today is sometimes in the hospital, there's plenty of room, and but in skilled nursing facilities are just jammed. Who's
Right.
in charge of you is the hospitalist from the hospital still involved once you get to a skilled nursing facility?
The hospitalist is no longer with you. You've moved on now to a skilled nursing facility provider, a physician there that's going to oversee your care. Again, someone that you don't know, that doesn't know you. They call them sniffists sometimes because they're in a SNF, skilled nursing facility. But this is someone who deals with chronic conditions, exacerbations of chronic conditions. So they're going to oversee, but they have a lot of patients. And many of these physicians will go from facility to facility. Some of them have their own private practice on top of being a sniffist. So they are very busy people, and they are hard to track down, and they're hard to get a hold of. I can tell you that from firsthand knowledge.
I can tell you from firsthand knowledge as well. So here, even there, knowing who your agent is and having your agent involved in your Medicare medical care is even more important in a skilled care facility than it is almost in a hospital.
Yes.
Because they're a lot busier. It's kind of hectic.
Yeah.
And so your agent really needs to be involved with this.
Yes.
Now, Medicare pays full board if you've been in the hospital for 3 days plus one, pays for every day at a skilled nursing facility up to 20 days. After 20 days, Medicare pays 50% of the bill. So, if you're under an HMO or a PPO, you need to know what those rules are because every one of them is a slightly different. Some of them don't require a hospital stay, others do. But again, this is the time to kind of know what the rules are. Once you're out of the skilled nursing facility, you go into what's called custodial care. Does Medicare pay for custodial care?
So Medicare can be a payer if you're in a skilled nursing facility. I'm sorry. I'm thinking about Medi-Cal. I'm sorry.
Yeah.
Let me back up 2 steps as Pete looks horrified. In terms of Medicare paying for custodial care, they do not pay anything towards that. It would be like asking Medicare to pay for your room and board wherever you are living. So that doesn't happen. One payer is Medi-Cal, but for a lot of people, they are paying out of pocket for custodial care. When we say custodial care, we're talking about activities of daily living.
And you got a list of what that
We do.
means.
You probably want to see that list, don't you?
Yeah,
Okay.
I love that list because
You do love that list. Okay.
yeah,
Let
because
me get you your list.
yeah, and the
There we
reason for
go.
that is that because um, uh, long-term care facilities use ADLs. I mean, the hospitals use the term ADLs. Long-term care insurance uses ADLs. That's the language that's used for custodial care. And so, if you have trouble bathing, if you have trouble dressing, if you have trouble toileting, continence, ambulating, transferring an ambulation, what does that mean?
So transferring is whether that's transferring out of bed to a wheelchair. Maybe it's transferring from a wheelchair to a commode chair. Ambulation obviously is the ability to motor around your home or wherever it is that you're living, and to be doing that safely. Some people can do that, but it's not safe and they're just heading for a fall. So we want to make sure that someone who has challenges in these ADLs is getting support, obviously, or they are going to end up back in the ER again.
Yeah. Eating and cognition as well.
Mhm.
So many, and we'll talk a little bit more about long-term care insurance a little later, but uh, um, if you have 2 or 3 issues here, I mean, you need help.
Mhm.
And, in today's society, what happens usually is because women live longer, women are the caregivers. They help their partners bathe, dress, toilet, continence, eating, and help with cognition. Well, the statistics are just horrible
Mhm.
about the caregiving spouse dying before for the person that they're caring for. And it's you've got to be start talking about some of this stuff and 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 hire a caregiver. Let's go back to the other slide
Okay.
and
Alrighty.
let's talk about we talked about custodial care and that's caregiving and we'll go into the numbers in a little bit, but let's go to Medicare. What is it?
So Medicare, as many of you probably know, is our federal health insurance for those folks who are 65 and above. It's also available for people who have certain conditions that are younger than age 65. Sometimes people may have a disease such as ALS, Lou Gehrig's disease, also called that, chronic kidney failure. Those kinds of things would qualify an individual to receive Medicare. It has possibilities in different areas. So there's different parts of Medicare. Part A and B are pretty common with original Medicare, obviously, but Part C is a Medicare Advantage plans. So they tend to roll up all services, all parts into one, and they have to follow Medicare rules. They just can't go out and just have their own sort of plan. They have to follow what Medicare guidelines are, but they package it differently and they have sort of different rules. So again, it's a matter of really asking a lot of questions before you choose your plan. And if there's open enrollment times that come through the year and you're not happy with your plan, you can certainly make some changes to that. I just want to put in a plug for one thing actually here. There is a document that I print out every year. It's called Medicare and You, and then it just has whatever year it is. So Medicare and You 2025, and it's the official US government Medicare handbook. And I print it out. It's got lots of wonderful information. Some of the things that Pete was just talking about in terms of how many days in a skilled nursing facility are covered by Medicare. It's got a lot of details about that. So it's a wonderful reference. Again, it's called Medicare and You and the year 2025. But I think it's a wonderful reference, and you can just print it and refer to it periodically or just look at it online.
Yeah. Don't fall in love with your insurance company if they're not providing the services that you have. Gosh, October change. The Medicare Part C, the private insurance companies receive when you sign up for, let's say, a Medicare Advantage plan. That insurance company receives a little over, I believe today, it's $1,000 per month, a little bit more than that, per individual who signs up with them program. And now that Advantage plan or insurance company is in charge of all of your medical care. And it's kind of a crazy system because they make more money the less you use their services. So it's, so please understand the money flow. Uh, 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 Medicare, when you use Medicare, you can go anywhere to see any doctors, but make sure that you have a supplement. And not all the supplements are exactly the same. So, where can someone go and learn about some of this stuff from a knowledgeable, neutral source?
Mhm. I tend to refer to Medicare specialists myself, people that I trust, not just anybody, but people that I know are credible and do this kind of work for the right reasons, because they do receive, once someone's signed up, they do receive reimbursement. However, find someone that is credible doing this kind of work. And they are people who are very well experienced and understanding of the different plans, whether that's straight original Medicare or whether that's one of these managed Medicare Advantage programs. But that is where I tend to ask my questions and also send my clients to.
Yeah, I usually refer people to the Council on Aging, and we'll have a slide on the Council of Aging in a little bit. But they're a neutral nonprofit. They operate here in Orange County with the Ombudsman program and some others, and we'll talk a little bit more about that. But the medical care system is in a total major change. Uh, Hospitals are buying one another out. Uh, they don't call them hospitals anymore. They call them hospital systems. So they have rehab, skilled nursing, they have prescription drugs, they have urgent care, they have
Hospice, home
hospitals,
health,
home health.
yeah,
The whole area of the
everything.
medical industry is changing. And so you need an advocate and somebody to help you guide through the system.
Mhm.
You're talking about high cap here through the Council on Aging. What does high
Yeah.
cap do?
So that is what you're referring to there, Pete, in terms of getting the counseling about different programs. And again, as he says, it is a neutral organization. They're located here in Santa Ana, wonderful organization. Even if you go on their website to check out what other programs they have going besides the HiCap program, but HiCap is dedicated to learning and teaching about the health insurance options that people have out there. You can call them on the phone, you can have a one-to-one conversation with someone there that's very knowledgeable. There's also seminars that they hold at their site in Santa Ana. There's also a hotline if you have a quick question you want to call them on the hotline. But they're a wonderful resource, not just for this program, for other programs as well. Excuse me. They have the ombudsman program that we'll talk about whenever Pete goes there. But this is your really great resource for the Medicare conversations.
Yeah. And again, your agent for your medical care needs to know about this resource, because we tend to think that if we go into the hospital or a skilled nursing facility, that if we're aware, well, that's great, but the individual, maybe one of your children, will not know about this because they're not there as far as age is concerned. So it's not at the top of their list to know, but it's a great resource.
Yeah.
Let's go to the next slide. Paying for long-term care. Wow. Yeah. Uh, many of us, and there's lots of statistics out there, but the statistics that we are most likely to focus on is the statistic that that will get us to buy something, whether it's an insurance policy, whether it's a ADU, or fear is a great motivator to find a cure for whatever ails us. But the fact is that many of us, if not most of us, are going to die before we need long-term care assistance. If you're over 80, the statistics show that you'll need care for 3 months or less. So this is not uh, um, a major drain. However, there are some of us who may have a stroke early, may have dementia early, and maybe need long-term care for an extended period of time. And so we need to kind of plan for that. What I usually suggest is that, especially the cost of caregiving has increased dramatically. Today, what are our agency charging, Leanne?
I see here in Orange County about $38 to $42 an hour for caregivers these days, which if you're getting 24/7 care can add up very quickly per
Yeah.
month.
And you might not need, and most of them have what's called a 4-hour minimum.
Mm-hmm.
So, and it's absolutely hard work. It's
Yeah.
unbelievably difficult.
Yes.
So you have to combine maybe with friends and family and with professional caregivers. Um, Women are the number one caregivers in the United States, but they need help, and they're reluctant to pay the care for caregiving services. Men are much easier to hire a caregiver. We're absolute sissies when it comes to medical care, but think about it. One of the problems too is that in paying for caregiving, and you have named one of your children to be your trustee and your advanced healthcare agent, is that they may feel that they're spending their inheritance on your care. Make it clear that it's your money. It's not theirs yet until you die, and they need to spend your money on your care. It's the old adage of if you're in an airplane and there's turbulence, put the mask on yourself, and then you can take care of other people. So, the third point there is to live with your children. My mother said, if I had to live with you, I'd rather die. But so she lived with my older sister, so that was that was a good thing. And we made it so that she lived independently within the same household. Um, Out of pocket funds, there's no insurance. Excuse me. There's You have to spend down if you want government help, and that's considered Medicaid or Medi-Cal. And we'll talk a little bit about that a little later on. But most individuals own a home and they have some monies. What I see a lot of times is that people don't do a two-step process. Meet with a fee-only advisor, see what the caregiving costs are, and do some cash flow planning. And so try to do that first before you go out and purchase long-term care insurance or caregiving services. See what you can realistically afford. We're going to talk a little bit about transferring the cost to an insurance company. Today, many insurance companies are not offering long-term care. Genworth is probably one of the few. And in long-term care insurance, there's all sorts of different models. And so if you have not looked at your long-term care policy, please do, and have your agent look at the care policy, because they're the ones that are going to initiate that policy. So a lot of times you have what's called an elimination period. Anywhere from 30 days to 90 days is most common, and that it doesn't take effect immediately. And the reason for that is it's cheaper if you have a 90-day elimination period where you're actually paying a caregiver or a caregiving agency for the long-term care, because if you're 80 and over, most people die during that period of time, so you don't need that to use that policy. There's also the inability to perform the activities of daily living. They actually will send out a nurse and to review you and to see whether or not you can bathe, dress, toilet, continence. Well, what do most men do when they have a female nurse ask them if they can do dress or toilet? They're going to try to do their best and do everything themselves. That's not the time. Because most insurance policies require you to at least not be able to do 2 or 3 out of the ADLs. So again, ADLs are absolutely that they're understanding. If you can't button your shirt, you know that's an ADL. I mean, you can't walk around naked. Although probably, Leanne, you've seen a few.
Yeah. Not everybody subscribes to that statement. So
Yeah. So uh, there's all sorts of new rules on employees too, as far as who you hire. So you can't hire somebody for a 10-hour day without giving them overtime. So
right.
you
Right.
need to understand the long-term care insurance policy, which is the Council on Aging, is a great help there. And you need to have your what is your long-term care plan? And you need to share that with your trustee and your healthcare agent. And yeah, it's just talk about it, especially with your family.
Yeah.
Let's go to the next slide. Medi-Cal.
All right. So this is in other states, it's called Medicaid. Here we have to be different. So we call it Medi-Cal. And it's financed by the state and federal governments, but it's really public health insurance. And so most of the people who are receiving Medi-Cal are lower income individuals. They may have specific disabilities. They may have specific illnesses. But again, it's something that you need to apply for and get through that process. They will assess whether you meet the criteria to be receiving Medi-Cal. The good news about this, and I have some clients myself who are also using Medi-Cal for custodial care. So when we were talking before about custodial care in the skilled nursing facility, they will pay for room and board. So in a room and board situation, it's about $400 a day if you're in a skilled nursing facility. So in this example that I'm thinking of a family I have right now, is she was in rehab for 100 days. She used all of her Medicare benefits for 100 days of skilled therapy. Came to the end of that, and so they were responsible for 100% of the bill. Luckily, they applied for Medi-Cal and got accepted. So if they had to pay out of pocket, it would be $400 a day for her to stay in that skilled nursing facility under custodial care. If she was staying there and there was no insurance coverage, if it ran out after that 100 days, she would have to pay $700 a day to be receiving that rehab in that same setting.
And by the way, don't let care facilities scare you. Sometimes they'll go, well, we only have 2 Medi-Cal beds.
Mm-hmm.
That's BS. And um, uh, most of your care agencies are happy to take Medi-Cal payments because of the amount of dollars that they receive from Medi-Cal. So, but there's a lot of scams out there regarding Medi-Cal. So be careful. There's, I think you have a slide on elder, oh, asset
Oh,
protected. Let me just, your home is still protected. You don't have to sell your home. Your vehicle, burial plan, some assets are protected. You don't have to be poverty stricken in order to get on Medi-Cal. But I recommend highly, if you're in a situation, to have again your agent for your health care or your trustee meet with an elder care attorney. And I think you have a slide on that, Leanne. I don't
yes,
remember where.
we do. Here it is.
There it is.
Timing. Wow, perfect timing. You're paying attention.
Yes. You know, even in the estate planning area, there's different specialties, and Medi-Cal has its own rules. Special needs trust have its own rules. Medicare has its own rules. Um, I- it Most attorneys are not familiar with them, and so. But someone who specializes in elder law will be. And they have a national organization, and that national organization is on your screen. And I have found them to be excellent resource to guide a family as to what to do, to draft documents, to maybe you might need a professional fiduciary. They use them a lot, and they can recommend someone in the area if you're not there. Because a lot of times we have moved away from our parents, or they live in another state and we're not sure what's going on there. So this professional association is just an excellent resource.
Mm-hmm. Yeah.
Options for long-term care. You can live in a skilled nursing home, not the most desirable. Um, there's, uh, gosh, I don't know how many skilled nursing homes are there in Orange
Mm-hmm.
County. I do know that the small boarding cares, there's over there's gosh, I think there's over 6,000 or 7,000, between 6 and 10,000 boarding cares in Orange County alone. What is a board care?
A boarding care is something I didn't know about till moving to California. It's usually in a residential neighborhood, and you probably have driven by many of them, and you didn't know the difference between a family living in there and a boarding care setup. There's usually 6 people or below living in a home. Most of them are older folks. There are some special arrangements for younger people, but for a residential care facility for the elderly, set up. There'll be 6 seniors in there. They all probably have various needs in terms of activities of daily living. So they need to have around the clock supervision. So that would be helping them up to the bathroom. That would be helping them dress, get their meals, assist them with their medications each and every day. So there's caregivers living in these homes. Some of them are awake at night. Some people don't have awake staff at night. So that's another good question to ask if you're placing a loved one. But these are homes that are throughout, as Pete says, there's hundreds and hundreds and hundreds of board and care homes. You also have assisted livings that are larger than that, right? You can get into some that hold a lot of people, and you may pay something from $3,000 all the way to $12,000 a month for some of these places. The upper end ones that are very fancy schmancy are getting up into over $10,000 per month. But there's certainly a lot of board and cares that are smaller, more intimate, that people prefer rather than these larger organizations and facilities.
Yeah, I'm paying for an assisted living facility. For one individual, I'm paying about 14,000 a month, and for
Wow.
another individual, I'm paying 18,000 a
Oh
month.
my gosh.
So um, uh, for the board and cares, the smaller board and cares, they range in price from 4,000 to usually 12,000 a month, depending on how much care. How do you pick one of these? It's
Yeah.
it's that's the
Yeah.
hardest part. Uh,
Yes.
they uh, they change ownerships quite often. Some of them are owned by private equity firms. They have Sunrise and others that are national firms that they're for profits, and they look like hotels.
Mm,
And so
yeah.
what I usually try to do is try to find out how long the employees have been there.
Mm,
And the reason for that is because the employees make the difference as to what kind of care you receive. And if they are happy there, receive a good pay, then I think you will get good care. If there's a major turnover of employees, there's no, because even if you have dementia, you become attached to other people. We're social animals. And so we need caring people in these facilities. And so if some of these facilities are just looking at the bottom line dollar, and you need a place that actually cares about you besides the dollar.
mm.
There's also home care, and that's where we talk about caregiving services, where you can get a caregiving service from 4 hours to 24 hours a day. And the pricing is all over the board as well.
Absolutely. One thing I'll just go back, Pete, if I can, and sort about the assisted living is these assisted livings for retirement places are overseen by the state. So the California licensing division there is a good place to go online and just check out what the deficiencies are. If you found a place that you think might be good, it's kind of close to where you live. And you want to go on and check and see, well, how do they do with their surveys? And unfortunately, they don't get out to be surveyed a lot, but they do have surveyors come out and check, is the refrigerator the proper temperature? Are people being socialized? Are they in this, congregate area? Are they being stimulated cognitively? They evaluate all those kinds of things. So you can go on, and also for skilled nursing.
Do you remember the website?
It's Community Care Licensing Division.
Community Care Licensing Division?
Yes.
Okay. Google that.
CCLD. Yeah.
It's a
Yeah.
great idea. Thank you.
Yeah. And then also for skilled nursing, you can also go on to what's called Medicare Compare, and you can take a look at some of the deficiencies, et cetera, for the skilled nursing facilities. It's not only one tool to use. You have to ask a lot of questions. You can call the Ombudsman program again and ask about a specific nursing home that you might be looking at. But Medicare Compare is another source. Sometimes, I would probably argue against maybe some of the results, but again, it's a piece of the pie, right? When you're trying to put together the whole picture of where you want to have a placement for your loved one or for yourself, perhaps. With home care, it's a little bit harder to have sort of that objective evaluation of home care companies. That's a little bit tougher. We haven't made it that far yet. But again, asking a lot of questions, interviewing a few different companies. If you have a care manager, they will be tied into some good home care companies and give you recommendations. I get calls all the time saying, who do you like for home care? And they don't have to be a client of mine to ask that question, but I do have some that I prefer to work with. So getting connected with people in the community who know these organizations will give you a really good resource for making decisions.
And if you're going to, and if you're going to hire somebody without them coming from an agency,
Mm,
make sure that you have an independent CPA provide them the normal employer-employee relationship so that you're withdrawing taxes, etc., just like an employee would, and and make sure that your home that that the insurance on your home covers the caregiving services.
mm.
So I usually increase the home insurance quite a bit if I hire somebody independently and I have a payroll service paying the caregiver. So you can still hire private individuals, but just do it from as a business-like manner.
Yeah.
Um, let's see what else. Again, all of this takes time. And so your agent and your trustee need to be involved in doing this. And so in selecting whomever you're going to choose to be your agent for your health care, uh, don't have them be as much as possible as local as possible. If they're a CEO of a corporation, they may not have time to do all this. They love you and care for you, but the timing is just inappropriate. So there are professional fiduciaries that will be your agent for your health care, and there are individuals such as yourself, Leanne, willing to be
Mm.
an agent for someone's health care legally?
Again, that's a really good question because some of us will not. So I will never take on that role. I think it's a conflict of interest for the work that I do. But I have heard that other individuals would do that as a care manager. I do really feel strongly it's a conflict. So that's why I refer to fiduciaries to take on that role. It's something that I won't do.
There's a question, which is an excellent one, and that is, well, what if I take out a reverse mortgage on my home and to pay for the long-term care? Well, there's a little catch in the reverse mortgage market, and that they don't tell you about. Once you move out of your home, and you do not intend to be moving back into your home, the reverse mortgage company can put your house up for sale. You cannot sublease your home if you have a reverse mortgage on your home. In other words, you can't rent it out. So before you go into a reverse mortgage to tap into the equity of your home, make sure you see an elder law attorney or you become aware of some of the pitfalls of a reverse mortgage. And it's very expensive. It's not free. And you have to understand the interest rates. There's lots of reverse mortgage companies out there, and they vary dramatically. The last thing I would do is hire a reverse mortgage company that advertises on television that has a major spokesperson, because that one is going to be more expensive and more restrictive just because of their exposure.
Mm.
So, just again, this is a money trap. So, uh, it is great to be able to use your equity in your home, but you got to do it wisely. And there's a heavy commissions involved in reverse mortgages. Uh, it's gotten it's so fraught with technicalities that the law requires that you go to an independent third party to see whether or not the reverse mortgage is good for you. Whether that third party, don't have a lot of confidence in that third party. From my point of view, you need a fee only fiduciary advisor to run the numbers for you. Do the cash flow analysis, see what your net worth is, see what asset allocation you have. Uh, you, one, you're not going to be paying any taxes if you go into a long-term care facility or you need caregiving services at home because all of that's going to be deductible as medical expenses. Two, you're not going to go on a cruise. You're not going to go out to dinner. In other words, all those other expenses are going to be reduced. So you got to look at how much money do you need on a monthly basis for your care. And that's the most important thing. Let's go to the next slide.
Can I say one thing about home care?
Absolutely.
I just want to emphasize what Pete was saying about hiring privately. I've been doing this work for almost 15 years, and I've heard some really sad stories about their favorite caregiver who was a private hire came back and sued them for XYZ. So just to emphasize, getting someone to run payroll, as soon as you hire that person, I mean, you become the employer. And that requires you to have the liability insurance. It requires you to have workers' compensation, do the payroll just as you would do for any employee if you were working your own company. So I just wanted to emphasize what he said about that. It's a really important point.
There's a law firm in Westlake in Los Angeles that just calls on caregivers and to try to get them to sue the family.
Yeah.
So it's out there, and what they do is file a lawsuit, and then we'll settle with you, for thousands of dollars, and 40 to 50% goes to the attorney. The caregiver gets slightly a substantially lower amount. So they're out there. So we follow some of the employee rules when hiring a caregiver.
Absolutely.
Advanced care planning. The Advanced Healthcare Directive. Gosh, we talked a little bit about, quite a bit about it. What your agent needs to know, do they have the time? Where are they located? Have you had the conversation as to what you want? Where do most people want to die?
At home.
And where do most people die?
Oh. Well, I think most people die at home?
No, 85% of individuals die in the hospital.
How many?
85%.
What?
Yeah.
Okay. All right.
Maybe it's changing in the last year or two, but that's
a lot.
Yeah. So talk a little bit about palliative and hospice care, because these things are really important for your agent to know.
Yes. So this is one of the most important topics I think maybe Pete and I talk about in general. I do a lot of presentations on advanced healthcare planning, and it is a critical piece. Anybody 18 and above should have an advanced healthcare directive. Everybody. And it seems weird to say that of a, barely out of their teens kind of person, but we don't know what's going to happen tomorrow, right? So we need to know, do you want to have certain care at that time where decisions need to happen? And that's why the point on this slide is that the document, the Advanced Healthcare Directive, is extremely important, but the discussions that surround that document are even more important. Pete has really emphasized today the inclusion of your agent and thinking about who the best agent would be. Sometimes the best agent is not a loved one. Sometimes those are people who really struggle with pushing through your decisions, that you don't want to maybe sustain, you don't want to have CPR, or you don't want to have a feeding tube. Sometimes it might be a friend who will stand up for your choices and will really advocate for you when the time is happening. So the discussions around this, I always talk about having discussions around time where family comes together. Maybe that's at Thanksgiving, at Christmas, and spending some time talking about what are the decisions that mom and dad want to make? What are the decisions that all of you sitting around that table want to make? Doesn't matter the age. I could be run over by a train tomorrow. I do not want to be kept on life support. So it could happen to any of us. So having that documentation is extremely important.
Conversations there. You can get an advanced healthcare document free from it's online.
Oh, here we go.
Yeah, from I like the California Medical Association one. The Veterans Hospital, every hospital will give you one. Council on Aging has their, usually attorneys will draft one for you as part of your plan. But that just gives the person legal authority to make decisions. But most people spend less than 10 to 15 minutes talking to their agent and say, don't take any extraordinary means to keep me alive, or do everything. Well, I wish life was that simple. It just isn't.
Yeah.
If you go into the emergency room, they're going to try to do whatever they can to stabilize you as much as possible. If you get intubated, wow. If you're intubated, to remove that tube from your lungs may cause you to die. And so that removal is a major decision. And who's going to make it for you? Not you. You're out. So, so talk a little bit. Let's see. I think you're going to go through the hospice and your way booklet. I love it.
Yes. Do your way there, Pete, because I know you like this document a lot.
Yeah, it's a booklet. It's available. It starts the conversation. I like it because it's not a narrative. It gives you multiple choices. Sit with whomever is going to be your agent. Let them complete one themselves so that you have a conversation about it. What's your value? What would you do? And it gets that conversation started. It asks whether or not you want hospice care. It asks whether or not you want medical aid in dying. It asks, who do you not want me to listen to? It's about, living is about quality of life. We live in a community where we have some of the best medical care in the world. I mean, today, here in Orange County, it's not a matter of getting good care. It's the bad news is, when do you want to stop that good care? I mean, we can do procedures. You could have procedures done. You can live mechanically. There's lots of things that can be done. The question is, what kind of quality of life are you going to have? And that's, from my point of view, is the key that you need to discuss with your agent. So
And we've
there's
talked a
no
lot about
wrong answers, by the way.
we've talked a lot about agents today and the importance of the conversations with your agent. But one thing I just want to point out here before we move on is that you should have a minimum of 2 agents on your advanced healthcare planning document. Yes. And
you could have up to 5. You don't,
yes.
Doesn't have to be limited.
So if someone, your first choice, maybe they've, passed away already, or you've divided your relationship over time and they're no longer in your life, and it defaults to the next in line. But try not to choose people that have equal decision making. In my mind, that creates a lot of animosity because of, especially if it's family members, they may not agree. They may not be taking into account what you discussed with them. And you've got two people that have equal power in decision making. And I think it gets really messy.
Yeah.
So have at least two, if not three. And as Pete said, if you want more than that, you can do that too.
And you
But
do
I
them
think
in
that's a really good idea.
succession. Yeah, you
Yeah,
do them in succession. You
right.
don't do co, and you
Yes,
make it practical. Sometimes the spouse is not the best choice
right.
because they're involved in your love and they may
Yep.
not be able to perform what you want them to do because of the caring that they care about you. Uh, maybe your children aren't the best. So, you gotta look at this. It's your life, okay? And nobody else's. A lot of people are recommending a pulse. What is it?
So the POLST form is different from an advanced healthcare directive, but you should still have an advanced healthcare directive. Everybody needs one of those, full stop. This is an additional form for people who are frail, they've got multiple health conditions going on, possibly showing some decline. We had a lady in our class yesterday that looked pretty healthy to me, and she said that her doctor wanted her to fill out one of these forms. So it's not appropriate for everybody. It's appropriate for people who are becoming frail and declining over time. But they're physician orders. So when someone goes to a hospital, maybe 911 is called, this form is a doctor's order, and the healthcare team has to follow these orders. So again, it should be used in tandem with an advanced healthcare directive, not instead of. But it talks about things like, do you want to be resuscitated? Do you want to have CPR? It talks about what kind of treatment do you want if we do resuscitate you? Do you want to be on a feeding tube? Do you want to be continue to be ventilated? Or do you want to have comfort focused care? So say someone's coming to the end of their life and they're like, no, I'm kind of done. They can fill out one of these forms because, as Pete has said earlier in this presentation, if you end up in the ER or your loved one does, the default for that team, unless they're told otherwise, is that they are going to save you as best as possible. That is their goal. If your goal or your loved one's goal is not the same, then one of these forms here, like a POLST form, that is the only way to guarantee that because it is a doctor's order. So choosing comfort measures only means no CPR, no feeding tubes, no resuscitation in terms of ventilation over time. It's comfort only. They will keep you comfortable. So it's a really important form. I've seen many go by that are unsigned by the doctor. A doctor's order is not valid without the doctor's signature. So if you're going to use one of these forms for yourself or a loved one or a friend, just make sure that it's completed fully. All the little boxes are filled out. The doctor has signed it. The legal decision maker or the person themselves, if they have capacity, sign these forms. Way too often I see that they're not completed properly and they're useless.
Yeah. It's a tool.
It's a
And,
tool.
yeah, that's a necessity. A physician's order is God speaking. You know, uh, you know, they wear white coats for a reason. uh, that is you can't get stronger opinion or order in the medical world than a physician's order.
Mm-hmm.
So that pulse is very, very, um, in the right spot. It's absolutely a wonderful tool.
Mm-hmm.
But
Yeah.
please don't get it until you absolutely are in the last 6 months or a year of your life and you understand what's going on. The typical primary care physician has so many patients that they may not know you intimately. So this is not a form that you complete when you're healthy. This is something that you look at once you maybe have a particular disease or cancer or Parkinson's or whatever, and you've had a good conversation with your physician. Because what does extraordinary means to keep you alive? So does that mean CPR is extraordinary? Does that mean being intubated is extraordinary? Does that mean a feeding tube is extraordinary? It's not common in the medical industry what is extraordinary and what is not.
Mhm.
And so you need to have the conversation. Here we go with some of the healthcare decision aids: CPR, artificial hydration, tube feeding, ventilator. You want to make a comment on any of those?
I do. I just want to say that overall, I find this website, Coalition Compassionate Care California website, they have all of these forms here that talk about what do these different things mean. So I think it's dangerous to assume that the public understands what it means to be ventilated. So, as Pete has said, it's a conversation with the doctor. I remember I was working with hospice or in hospice, and they came out, Medicare came out with a billing code to encourage primary care physicians to have conversations about end of life choices. They were tempting them with money to try and ensure that they would have these conversations. How sad is that? But they are busy. They're trying to get through a whole panel of people every single day. So my encouragement here is to, again, have the conversation surrounding the Pulse Forum, or in general, have the conversation about these forums, but also take a look at decision aids like these that explain what does it mean when someone has a feeding tube? What does it mean to have artificial hydration or nutrition? What are the risks? What are the benefits? Again, it's just getting educated about making these really important decisions for yourself and with your loved ones. So that's why I think this website is incredibly helpful.
Yeah. One of the questions in the Your Way booklet is, um, do you want me to spend your money to take care of you, or do you want me to shorten your life so that you can pass on more money to your children? Think about that.
Mm.
If you say you want more money being given to your children, I tell the individual that I'm sitting with, I says, I can't do that. I said, you got the wrong individual to be named in your healthcare document, because your money should be used totally for you, uh, for your quality of life, not to shorten your quality of life so that your kids can get more money. So, these are the kinds of issues that are not, there's no quick answer. You need a conversation on those things.
Mhm.
Let's go to the next slide.
All right.
Palliative and hospice care. What is it?
So palliative care is something that's come into our world over the past several years. I've got a website here for you that has some excellent articles and information on the difference between palliative care and hospice care. But basically, palliative care is really for a time period where people are living with a very serious illness. They could be having a cancer diagnosis that they're working through, getting chemo, some surgery, radiation. It focuses really on providing relief from symptoms that go along with a serious illness. Doesn't matter what the diagnosis is. You do not have to, as you are with hospice, be within 6 months of passing away. This is for people who are actively being treated. What they're trying to do is provide the same supports that happen within hospice to people who are before hospice is appropriate. So earlier in the disease process,
Yeah.
they find that it helps with the kind of care people are getting. It helps with decreasing the stress on the patient as well as the family members surrounding that person. It helps to save money because people are not going back and forth to the ER trying to manage symptoms. So it really is providing the same kind of support hospice has in terms of social work support, psychosocial, emotional support, people who are specialized in palliative medicine, meaning symptom management like pain management. Maybe people have intractable vomiting from their chemotherapy. So it's really bringing those supports earlier in the disease process, which I think is fabulous. This palliative care team works alongside the regular team. So maybe the hematology oncology team, maybe the neurology team that's treating whatever illness is going on. The palliative team is involved with that team as well. So you're really getting more support from more specialists in terms of providing the extra symptom management. It's appropriate at any age. Kids can have this kind of care in any stage in a serious illness. So again, it can be much before hospice comes into the picture. And it's with the curative treatments. They're not asking you to give up curative treatments. They're saying, we understand you still want to have your chemotherapy. We're going to help you to manage the symptoms that go along with that, whatever that may be. It may be the anxiety, it may be the nausea. They're going to help to manage all those kinds of things. So that's what palliative care can do for an individual.
Not every care plan offers palliative care.
Mm-hmm.
So you want to ask. It's come in because it's cost extra money. So some insurance groups offer palliative care, others don't. Uh, let's see. Any additional things that you want to talk about on this slide?
You wanted to, I think, the
I want to
last.
get into do some what is hospice
Yes.
compared to palliative care.
Yes. So fast forwarding through those other slides that are basically saying the same kind of thing. In terms of hospice care, that is really again dealing with end of life. So we're talking about someone who does meet the criteria of having a life expectancy of 6 months or less if the disease takes its expected course. Two physicians have to certify this. Usually one person is a primary care that knows that person well. The other is often the hospice physician, maybe medical director of the hospice, taking a look at the records and saying, yes, it seems like this person is coming close to the end of their life. And of course, this is a voluntary thing. So we want to make sure that the patient, if they have capacity, or the responsible party are on board with the kind of philosophy that hospice has. So those are the criteria. And it could be, again, there's many different diseases that will put someone in a position to be appropriate for hospice. We know that Medicare covers hospice 100%. Even people who have a Medicare Advantage plan, they revert back to the original Medicare for this particular service, and it's covered 100% in terms of the team that surrounds the patient, in terms of durable medical equipment. It doesn't cover all medications, so don't be surprised if some of the meds aren't covered. They will cover the medications related to the terminal diagnosis. So if someone comes on for end-stage heart disease, they will cover all the cardiac related medications, all the comfort medications, but they probably will not pay for like the levothyroxine for the thyroid, or maybe a cream for some skin condition. They won't probably cover that. But that's just because they pay for everything related to the end of life situation.
It's a wonderful program and it's completely paid for by Medicare.
Mhm.
But your Advantage plan is not going to receive the dollars from the federal government that they were getting before, because now the payment is going to go to the hospice organization. So can money influence a medical decision? Yes, it can. It shouldn't, but it can. So what I see out there is that uh, getting on hospice is done in the last week of life or in the last 2 weeks of life. Uh, people can people get on hospice and get off of hospice at any time, or is there a rule that you have to stay on hospice a certain length of time?
So you can come on and off. You can even go to the hospital if you want to. Sometimes people decide, you know what, they get scared and they're maybe short of breath and they panic and they want to go to the hospital. Absolutely. That person can go to the hospital. They'll come off of the hospice care benefit, but they can certainly go to the hospital. People do come on very late in the process sometimes, and it's a shame because they're not able to really take advantage of all of the services and the benefits that hospice has. The last week or two, everybody's scurrying around trying to get the symptoms managed, when really it could have been a much more smooth entry and ongoing support for the patient and family.
Yeah, and people who are, in their 50s and 60s and they say hospice, the first thing they think of is, okay, death. Well, doesn't mean that. Jimmy Carter lived for over a year in a hospice program. I've had clients who've had 2 years under hospice.
Yeah.
Uh, about 20%. the pressure is off, so to speak, of getting better. Uh, they can relax because it's all about comfort care. They don't have to have another procedure. It's just about pain management. They provide hospital beds, nursing care twice a week or 3 times a week. You can call them 24/7. You have somebody who can help the person bathe. You got somebody who you can call and to talk about what is the patient doing now? Should I panic? Like, it's just so wonderful to have that care. There are many hospice programs in Orange County. So interview 2 or 3 so that you understand the philosophy. If you have medical aid in dying, some hospice programs will not honor that. Catholic hospitals will not honor that. So you got to understand religion. That plays an important part here as well, because in Catholic hospitals, they'll push you to palliative care, which there's nothing wrong with palliative care, but Medicare does not pay for palliative care. It has to come from the hospital or the care plan. Talk a little bit about the continuum of care.
Sure. So, in terms of how this all fits together, this palliative and hospice, this is a nice little graph, I think, that shows that when someone is undergoing treatment, and let's just pick cancer because I think it's an easy thing to talk about in terms of there's many different treatment modalities, and there's initially, there's a very aggressive kind of time frame where people are really searching for that treatment and that cure, if possible. And over time, there may be a development of symptoms, and that's where palliative care can start to come in. And that's where I see the referrals coming from for palliative care with my patients, is when the treatment is causing, some side effects and some issues. So let's get that palliative care team going side by side with the team that is actively promoting active treatment. At some point down the line, there may come a time where, maybe it's a year out, it's 5 years out, whatever it is, that maybe we're coming to the end of the trajectory for that particular disease process. And it becomes apparent that we're going to transition the palliative care over to the hospice care. They've been receiving a lot of support with the palliative care program. Their symptoms are being hopefully very well managed and tightly managed. And then they go on to the hospice care, which covers all the things that Pete was mentioning there. It's the terminal phase of the disease process. So they're going to have their durable medical equipment, their, the associated medications, the care team, palliative people that are going to be very, very focused on managing symptoms and easing that person through their end of life process.
Yeah.
After death, there is bereavement support available to the family and the loved ones surrounding that patient who's passed, and that goes on for at least 12 months. I do know of a couple of hospices that go beyond 12 months in terms of bereavement support if needed.
Yeah, if needed. Yeah, so the end of life care is it's a money issue that people don't like to talk about. Death, people certainly don't like to talk about death. Um, uh, you hear language, uh, the patient, don't give up, fight on. You know, I hate that kind of language because it makes it seem like if you're the patient that you have somehow control over your disease. You don't. No matter what anyone says, if you have a particular type of cancer, and I don't care what you do at the present day, you may not make it, no matter what your kind of outlook is. Uh, if you hire or you name somebody to be your advanced healthcare agent, um, forgive them up front. Okay. And why? Because one of the things that most agents are scared of is making the wrong decision, and which may cause your death. And so they tend to follow another procedure. Let's do another procedure. Well, if you do another procedure, your quality of life is really going to go downhill. If you're in radiation, your quality of life may go downhill. So have that conversation and allow your agent to speak on your behalf. And because they're going to be able to communicate to the doctor that, hey, they've talked to you and you have talked intimately about exactly either to continue treatments or not to continue treatments and when that should stop. We're all going to die, so you can't prevent it. And you want it to be with dignity, and you want it to be free of pain, and it should be a family affair, as in my opinion, because it happens to all of us. Gosh, Leanne, we're at 11:27. Oh,
Oh,
go back.
go back.
Go back. No, I want your name and address.
My address.
Please, if anyone has a question that's personal, please email Leanne. She's awesome. And the profession, what we didn't show was the slide for your association.
Oh, yeah, we zipped over that one, I think.
Yeah, I
But
think.
yeah, I mentioned it and we didn't show it really. So let me go get that for you. It was right near the beginning here.
There's an association of care managers that Leanne belongs to, and other individuals uh, in her line of work. Talk a little bit about that.
So this is what I mentioned at the beginning, where this is our association. Not everybody's a member, as I mentioned, but you can go on here where the little orange tab is there, find an aging life care expert. And sometimes it helps to know what you're looking for. If you're looking for someone who is maybe more of a generalist, knows about some, maybe understands more about the benefit plans, you're probably going to be looking for someone more like a gerontologist, perhaps. Something that's more psychosocial related, you might want to have a social worker. If it's more clinically oriented, you may want to have a nurse care manager. So going in and understanding a little bit about what you're looking for. Care managers have a lot of different experiences. So again, ask the questions, interview people. And if you have just some general questions, many people, if you reach out to them and say, hey, I'm in your area, I'm looking for a home care agency or a hospice company, do you mind referring, to give me a couple of names of people that you work with that you respect? Most people, care manager wise, will give you some resources. You don't have to sign on to their program or anything like that. They'll just be willing to help you. So I encourage you to check out the website. There's lots of good information, and you can find a care manager on there.
And they have different specialties. So if somebody that you're caring for has a brain injury, that's how you start off. Do you have experience in the brain injury area?
Yeah.
If it's cancer, some people have more experience there than others. So give the care manager a little bit of a background as to the issues. And your agent for your care is going to be calling the care manager.
Right.
You're not going to be calling them yourself.
And one other thing I just want to mention is that if you call a care manager and they're not quite the right connection for you, most will say, you know what, I might not be the right person, but here's someone who, is more in line with what you're looking for. Why don't you try them? So very overall helpful group to get in contact with.
Yeah. All right. It's the end of the program.
All right.
Hey, thank you again.